Okay, so vital signs and monitoring devices. So we'll talk about which vital signs we're worried about taking in the field, so pulse, respirations, blood pressure, skin temperature, pupils, how we document those things, and how to use various monitoring devices. So vital signs are our kind of window to what's going on inside. So outward signs of what's going on inside. And we take them serially over time, and we can identify trends. So is the patient getting better, worse, maintaining? It's virtually every EMS patient. We're going to have vitals on at least some level of vitals for every patient. And actually, our patient care system doesn't let you get away with not putting in at least one vital for every patient. If that patient is, whatever, giving you the finger as they're running down the street, then they're running around so we know they're breathing, and yeah, basically that's what we document. Occasionally we don't get a full set of vitals or repeat vitals because we're too busy trying to do interventions and treat that patient. Sometimes a vital sign is more or less just going to tell you, well, you probably shouldn't have stopped to take time for that vital. You should have just gone faster. Okay, various vital signs. Pulse, respiration, skin color, temperature, condition, pupils, and blood pressure. So these are the ones that we mostly deal with out in the field. And somebody says baseline vital signs, that means that's the first ones that we took. And then any more vital signs we take after that are repeat vital signs. So pulse can tell you quite a bit. Again, we're just going to squeeze an artery where it lies over a bone. When you do it with your fingertips, you can get not just the rate, but kind of how strong it is. So normal rates for an adult is 60 to 100. Anything greater than 100 is a tachycardia. Anything less than 60 is a bradycardia. Whether that's significant for the patient or not, those are the numbers. Okay, so not every patient that has a tachycardic heart rate is in danger of anything. Same thing for bradycardia. So what would be something that would cause somebody's heart rate to be greater than 100, but we don't really worry about?
They were just in a car wreck and they're tripping out.
Sure, they can just be anxious, right? Just high anxiety gets you everywhere.
Exercise, if they were like going for a run and they passed out.
Yep, so if somebody's running around, working hard, their heart rate's going to be bigger than 100. How about less than 60?
Some people with like who are in really good physical condition or like naturally
Yep.
good cardio health, maybe under 60.
Folks that have good physical conditioning,
Low blood
long distance
sugar.
athletes, what's that?
Low blood sugar.
No, low blood sugar doesn't
No?
cause bradycardia.
Okay.
Actually, the opposite, it causes tachycardias.
Okay.
There's other medications, especially ones that control high blood pressure, that slow heart rate down.
Doesn't morphine drop your pulse rate as well?
It can slightly, yeah. It's not going to be as pronounced an effect as what it does for your respiration rate, but it does tend to slow things down a bit.
What about like alcohol or like controlled substances? Do those mess with your heart rate?
Depends on the controlled substance. So like your downers ones, like your barbiturates, like date rape drugs, those kind of things. Those will slow everything down. Meth and cocaine, other stimulants, jack it way up. So in general, above 120 or below 50, we consider a serious finding. But again, whatever, if somebody's out biking around or running or exercising, 120 beats is probably not anything to be worried about either. Again, normal situations. Medications that end in lol or lol, so metoprolol, propranolol, those things are beta blockers. People get them for high blood pressure, and they can make your heart rate be mid-50s pretty commonly. So you see that on somebody's medication list, don't freak out if their heart rate is low. You probably should freak out if they're taking that and their heart rate is 100 though. So besides the rate, we can check the rhythm. So most of you in here, if you feel your pulse, it should just be a nice steady thump, 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 thump. It doesn't go thump, 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 thump. It's not an irregular rhythm. Some people do have a little bit more of a wandering pacemaker. Their heart is a little more irregular. But that is an abnormal finding in general, have an irregular heart rate. If you feel a pulse, especially peripherally, it can be either strong, like if you're exercising or something, you can usually have an easy time feeling your pulse because it's just right. Versus a real thready or weak pulse, it doesn't feel like it has much to it. So the most common place to take a pulse is a radial pulse. You're going to go right on the thumb side, use one or two fingers, push in there. If you use your thumb to feel a pulse, you might feel your own pulse in your thumb. So that's why we use your fingers, not your thumb. The brachial pulse is on the inside of the arm. Should be able to feel it in here. That one's a little bit harder to find on adults sometimes. On kids, it's pretty easy to find. We're going to use that one on kids as a go-to. And your carotid right there on your neck, on either side. You've got two carotid pulses. And practice doing pulses. Again, kids don't have a lot of, or at least the real little guys, don't have a lot of neck to work with to find a carotid pulse. And my radial pulse is pretty hard to find too. So we're going to go for a brachial pulse for the little guys. Carotid pulse usually easiest to feel on the same side that you're on. We're not generally going to check a carotid pulse unless somebody is unconscious, unresponsive. It's just a little bit more up in people's space than they generally like. So if you're counting it by hand, we're actually going to count 15 seconds multiplied by 4. If the rate is real slow or it's irregular, then you should count for longer, 30 or 60 seconds. If you're not in the habit of wearing a watch, you probably should start getting into the habit of wearing a watch, at least for doing ambulance things. It's pretty hard to count a pulse without a watch. As I mentioned earlier, you can get a pulse rate out of these little pulse oximeter guys, which are generally fairly reliable, sometimes not. Respiratory rate, so this is how many times you're breathing in and out in a minute. So for an adult, at rest, 12 to 20 is the normal rate. If somebody's really calm, you can get down to maybe 10-ish per minute. 8 and below, I start to get worried. On the high end, 24 is not crazy high, but you start to think about whether you need to do some interventions for that. Respiratory quality, so how are they breathing? Are they moving air fairly easily? Taking deep breaths, do normal. Are they taking real quick little breaths, just that kind of thing? Be shallow breaths. Are they working hard to breathe? That would be labored breathing. They really got to work to get a breath in. And then are they making any noises? So wheezes, stridor, wet or chunky lung sounds. Sounds like they're breathing bubbly stuff. And we'll talk about lung sounds in a little more detail when we get to the respiratory emergencies chapter. For counting respirations, this is one of the harder vital signs to take. Most people don't have real obvious big respiration breaths all the time. They're just kind of subtle and sneaky about breathing. And if you're talking to them constantly, it's also pretty hard to get a respiration rate. So you kind of got to sneak that in to count their respirations. But we do count 30 seconds and multiply by 2, so you can't cheat this one and do the 15 by 4 thing. Breathing is just slow enough, you got to get the respirations in there. So we're going to document rate, quality, and rhythm. So they breathe in it. 14 in normal, 14 in deep, 20 in shallow, and pretty much all we're going to be breathing regularly. Occasionally you'll have somebody that's kind of having anxiety issues or something and breathe real fast for a little bit and then calm down and breathe fast, but it's not super common. Look at the skin. So we're doing color, temperature, and condition. So is it pale? Is it warm? Or is it cool? Is it dry? Or is it moist? So you have people that have naturally dark skin color. Other places you can look for pink worm and dryish skin, nail beds inside the cheek, inside of the eyelids. So abnormal skin colors, pale, bluish, really flushed, or jaundiced yellow skin. I've only seen real yellow skin like once, but it jumps out at you when you see it. What causes yellow skin?
Okay.
Okay.
Decay.
No. One of these things.
Liver.
Oh, liver.
Liver problems, yeah. Somebody's got chronic liver issues. You'll see that yellow jaundiced skin. Temperature can be hard to assess, especially if you're out in the environment somewhere. Largely it's hard to assess just because your own skin temperature plays a factor, right? So if your skin is cold, you'll think theirs is hot and vice versa. So you can use this back of your hand technique. Better just to use like the infrared thermometer guys. We want core skin temperature, not the temperature of their hands or feet or something. Because some people have better or worse circulation, and hands can be colder or warmer than core. For kids, we're also going to check cap refill. Capillary refill. So basically you push on the nail bed and make it turn white, squeeze all the blood out, and see how long it takes for the blood to come back. It should be within 2 seconds. If it's more than 2 seconds, that's a sign of poor circulation in kids. You can do it on adults. It's just not as reliable a vital sign in adults. Pupils. So we look at their eyes. Especially at their pupil. So your pupil expands and contracts depending on how bright it is. Out in bright sunshine, it's small so that you don't get extra or excessive light back on your retinas. If it's real dark, your pupils get real big. So what we're going to check for is that our pupils are equal and reactive to light. So if you have one pupil that's real big and one that's real small, that could be a sign of a head injury. It's not a real common sign, but it is a sign. And whether they're reactive to light or not basically is kind of a lower level assessment of mental function, whether there's still something working in there or not. Eventually, if somebody is far gone enough, the pupils start not reacting at all. So note their baseline size. Test for reactivity one eye at a time with a little pen light. Try and use like the little pen lights that are designed for this task and not like some mega spotlight flashlight thing. Flashlights have gotten increasingly powerful over the years, and yeah, it's pretty easy to carry a super bright little light in your pocket, so go easy on poor patients. Again, we're looking for overall size. Are they equal? Are they reactive? So if they're real constricted, what might that be a sign of? It's bright outside. The other thing can be a sign of is heroin or opiate overdose. So pinpoint pupils are kind of a telltale of any kind of narcotic use. Pinpoint pupils. Then dilated pupils, what can that be a sign symptom of?
Cannabis use.
Yep. Some hallucinogens like marijuana, get you dilated pupils. Might just be dark. And then unequal, again, some head injuries, especially you get it on one side where it's just affecting one eye kind of thing, you can have real unequal stuff going on, but that's not super common. Some people normally have a little bit of inequality to their eyes. So if that's the normal thing, that's the normal thing. Okay, then blood pressure. So this is a fairly telling vital sign, an important one. And changes in blood pressure are generally more significant than any one particular measurement. So we say a normal blood pressure is 120/80. But everybody's gonna be a little different. So we measure this with a sphygmomanometer. I can never get that one out, but a blood pressure cuff. And just use the right size of cuff. So these things come in like 4 different sizes. So infants, kids, small adults, and larger adults. Wrap that thing around their upper arm, pump it up, put your stethoscope there. And basically what you're listening for is the sound of blood coming back through after you've released pressure there. So when blood squirts past that pressured cuff, you look at the dial and see what the pressure is when the blood is able to squirt past through there, and that's their systolic number. That's the upper number. And usually you want the stethoscope up a little higher there. So again, when you first hear the pulse coming through, blood coming through there, that's their systolic. And you keep letting pressure out. When you can't hear it anymore, that's the diastolic. This just takes practice. We'll practice some tonight. If you are in a noisy environment, or just like the back of the ambulance is noisy enough usually, you can't hear what's going on, then you can do this by palpation, it's called. So you put the cuff on just like you would for the other way, except now you're going to check a radial pulse. Make sure you have a good idea where that radial pulse is. Then you start pumping up the cuff, wait for that pulse to go away, then you start letting the air out, watch the dial. When you feel a pulse again, that gives you your systolic number. And you can't get a diastolic this way. So your reading will just be whatever the number was, 110 over palp, say. That's what you document that is, 110 over P, so that people that read in your documentation know that's how you took it. That's why you don't have a diastolic number. For real little kids, like 3 years and lower, it's hard to get blood pressures. One, their blood pressure is really low usually, so like 90 over something is a perfectly fine blood pressure for a kid like that. They don't have a lot of arm space to get that little cuff on and your stethoscope, and they're usually not super cooperative at it either. So our automated machine, our cardiac monitor, we'll do blood pressures, and we'll often throw that thing on them with a real little cuff and see if it can do it. But in kids in general, blood pressure isn't as valuable a metric as other things. Usually pulse is more diagnostic as to what's going on. Kids just compensate really well, and so their blood pressure stays more or less the same no matter if they're dying or not. Temperature, so normal core temperature is like 98.6. If If you get wild deviations from that, you start not working very well. Everybody's got a little bit different temperature. And depending on where you measure it, depends on what kind of reading you're going to get to. So you've got to get an oral temperature in just about the right spot to get it to actually read what their normal core temperature is, pretty deep under their tongue. You can take temperatures mid-axillary. You're usually going to get a couple degrees lower reading there, but you can do it there, just stick it in an armpit. We're not going to go in for, what you would call it, any other more intrusive bodily temperatures. We do use the little infrared gun thingies, and those do okay. O2 sats. This measures how much of your hemoglobin is saturated with oxygen. So normally it's 96 to 100. I think most places say now 95 to 100. So if you get down to like 91 to 95, you're in mild hypoxia. Below 90, significant or severe hypoxia. Now, some people with chronic illnesses can have their normal be like 95 or lower. It's not healthy in particular, but you do see that on occasion. So these things are measuring circulation out there in a fingertip. And people that have poor circulation in general, or are in shock or hypothermia, these kind of things can cause that little sensor to read funny or not read at all. Carbon monoxide binds to those hemoglobins and looks just like oxygen to most sensors. So you can't trust your O2 little cheap finger sensors for patients that have been exposed to like smoke and or any kind of CO2, or not CO2, but CO issue. Our big fancy $30,000 cardiac monitors actually can tell the difference between CO and O, and will actually give you a reading on how much CO is in a patient's blood. So that's pretty handy. If people are wiggling their finger around, if they're wearing too much nail polish, or any nail polish sometimes, if they're anemic, lacking in red blood cells, any of these things can make that reading not work out. So in the end, if your patient looks like they need some oxygen, give them some oxygen. Don't rely necessarily on that little sensor to dictate whether you give your patient oxygen or not. Treat your patient, not the O2 sensor. Blood glucose. So we are allowed to prick people's fingers and read their glucose. It's not a bad thing to check for any unknown unconscious person. In Idaho, we do this with an optional module. And we'll try and cover that during the class. So that's a blood glucose monitor. And again, this varies by local protocol. We are allowed to do it. So you wipe the little finger off with alcohol, prep, poke it, get a little bit of blood. Get your reading. 80 to 120 is what we're looking for a normal sugar. If they're below 60 in their altered mental status, we'll consider that hypoglycemia. If they're above 120, then they're hyperglycemic, which is not something we treat. Hypoglycemia we can treat. We just give them sugar. Vital signs change as you age. Kids generally have faster pulses, faster respiratory rates, lower blood pressures. And as you age, it goes the other direction. So the older you get, in general, your pulse is going to go a little slower, especially if you're taking high blood pressure medication. Respiratory rates kind of end up staying the same. Blood pressures end up creeping up over time. Questions on vital signs?